countdown. Yes.
Have you joined?
I request all the other people to mute themselves, please. Nilima, once you give the countdown, I'll start.
Now we are starting.
Yes, madam, please go ahead. Start.
Okay, yeah. Thank you so much. It's an honor to invite all of you to this unique certificate course on pelvic floor. It's been curated so well by Dr. Suman Sinha and Dr. Kavita Banwal. It will be held for the next 3 days, 23, 24th, and 25th of September. May I now have the prayer song, please, Nilima? Prayer song alone you have to play because you don't play from our side. Thank you so much, Nilima, for that. It's an honor to welcome the office bearers of FOGSI, Dr. Jaydeep Tang, Dr. Parul Kotdwala, Dr. Madhuri Patel, Dr. Sheila Mane, Dr. Sarita Bellarao, and Dr. Parag Biniwale to this program, as well as the conveners, Dr. Kavita Banwal, Dr. Suman Sinha, and Dr. Vidya Dobi. As we heard, they worked so hard to bring in so much of registrations for a webinar and for a certificate course. Getting number of registrations quite good, but crossing 1,000 is a big number. And we hope to see a great interaction by faculty as well as the delegates today. And we've got 3 great coordinators, Dr. Meera Raghavan, Dr. Niharika Alu, and Dr. Meena Mahalingam. I'll just share the CV of the experts here. Dr. Sheila Mane Madam will be joining a little late. Dr. Parag Biniwale has joined, sir. Dr. Parul sir will join a little later, yes, so we'll welcome when he joins. And we request Dr. Suchitra Pandit Madam, who's the guest of honor today, to give us the blessings for this certificate course. And she is the past president of FOGSI, past president of the Mumbai Society, has been the president of so many great societies and organizations, and she's part of FIGO now. May I request Dr. Suchitra Pandit to bless the gathering, please?
Thank you very much. I think ICOG is doing a fantastic job by coordinating with the various committees and bringing forth, certificate courses. And this is one very unique one because the pelvic floor is always enigmatic. I've always been fascinated by the pelvic floor because in my year of presidency also, I had a topic, in fact, a conference dedicated the pelvic floor enigma, mysteries unraveled, and it was a 3 day conference dedicated completely to that. And second, I had the book on pelvic organ prolapse, because I used to feel that this is something which is relatively ill understood, but as a gynecologist and obstetrician, we need to know a lot about it. And I'm so glad that Suman, Vidya, and Kavita have racked their brains and come out with a very systematic course, which the first day deals with the basics, the second day goes into the pathophysiologies, and the third day deals with something more different, and particularly the how do you do the obstetric anal sphincter tear repair. So all the 3 days, I mean, I would have loved to have joined this. I hope there is a recording where in your leisure time you can watch this. But to get 1,000 number itself means that people want to know more about this. So once again, congratulations to the entire ICOG team, to the FOGSI team, Jaideep and Madhuri, for constantly agreeing to all that ICOG has to say. And Sarita is like the absolute smooth sailing captain, because she will make sure everything is well oiled and give it into the hands of a very, very capable person, that is Charmila. And I'm sure that this program will go on very well. And I met one of the experts just now, and I think he's also a boon to the faculty. He's Samir Pradhan, completely goes into the depth of everything. So whoever is going to learn from him is always going to be helped. And once again, thank you for having me over. And all the best for the workshop.
Thank you so much. It is always an honor and a pleasure to have you in any program, ma'am. You make it so you bless us with so much of kindness and it's always good to hear from you always. Thank you so much. And the next guest of honor is Dr. Sarita Bellarao. There's no need for an introduction to this great secretary because she has done it so smoothly this year, as Suchitra madam said. And it is always a pleasure to work with Dr. Sarita because she keeps it so easy and smooth. There's no hurdles anywhere, and always she lends a helping hand. She's been the president of the Mumbai Society in 21-22, joint secretary of FOGSI in 2017, she's been the chair of the quiz committee of FOGSI in 2009 to 2011, and is the secretary of the ICOG at present, as well as the chair of the West Zone India Representative Committee of RCOG. May I request Dr. Sarita to say a few words and bless the program.
Thank you very much, Dr. Charmila, and I'm really delighted that we are having this 3-day course on urogynecology and pelvic floor, and this time we have over 1,000 registrations, which was the scenario a couple of hours ago, so it may be even more than that. So I must
11:35. At present, it is
11:30. Excellent, excellent. So I really must thank our 3 pillars, Dr. Suman Sinha, Dr. Kavita Barnwal, and Dr. Vidya Thobi, who along with their coordinators have done a great job of organizing this program, contacting all the faculty and everything. Dr. Parul will be joining a little later for his welcome. So I think you can go ahead, and thank you so much, Dr. Suchitra. Thank you to our series conveners, Dr. Parag and Dr. Charmila, who I know I can always rely on, and it's making my tenure so much more easy. Thank you so much.
Thank you, Dr. Sarita. Now we'll go on to the conveners. They've done such great work for this program, and we're seeing lots of people who are joining, as Dr. Sarita was saying. And the conveners are Dr. Kavita Banwal. She's a senior consultant and lab surgeon from Samarpan Hospital, is the chairperson of the Urogynec and Pelvic Floor Repair Committee of FOGSI at present. And she's the associate professor of Lord Buddha Koshi Medical College, Saharsa. And she's received several awards, has written several books, and is a great academician. The next convener is Dr. Suman Sinha. She's a chairperson of the Vaginal Surgeries Committee of FOGSI. She's the director of advanced care and maternity care at Ranchi and a senior consultant of IVF and Infertility Center Ranchi. Has got an experience of almost 30 years in the field. Has got several awards and appreciation awards to her credit, and she has written several books and got several publications. They are the conveners for today, and the third convener is Dr. Vidya Thobi, who was the chairperson of the Food, Drugs and Medical Surgical Committee, as well as she's the vice president-elect for South Zone FOGSI. Madam has written several books and is a faculty who's sought after in many of the forums of FOGSI as well as ICOG. I welcome all the conveners and I hand over the session to them. And these are the requisites for the pre and posters. May I request one of the conveners to take over and introduce the program to the audience. Thank you so much.
Madam, should I start?
Yeah, you should.
Yeah. So thank you, Charmila Madam. So, namaskar and good afternoon to all of you. Honorable President FOGSI, Dr. Jaideep Dang Sir, Secretary General Madhuri Patel Madam, ICOG Chairperson Parul Kotawala Sir, Vice Chairperson Sheila Mane Madam, Secretary ICOG Sarita Bhalera Madam, and guest of honor Suchitra and Pandit Madam, and all the eminent speakers, chairpersons, faculty, and delegates. Under the leadership of Parul Sir and Sarita Bhalera Madam, Urogynec Committee, along with Vaginal Surgery Committee FOGSI, is organizing ICOG certificate course from 23rd to 25th September from 4 p.m. to 7 p.m. तेजो मंडिता उज्ज्वला भया मह्यम शक्ति शिवालिका यानी तेज से सुशोभित और उज्जवल समृद्धि से मैं शक्ति बंधी. With the increased life expectancy of the woman, many are spending more than 1/3 of life after menopause and seeking for various urogynecological problems like incontinence, pain, body dysfunction, uterovaginal prolapse, and even fecal incontinence. They are coming out and getting doctor's opinion to live a better quality of life. So now is an hour to train ourselves so that we can provide services and help them for a better quality of life. So our session is starting from anatomy, pathophysiology, neural control of micturition, and assessment and evaluation, which will be done by eminent urogynecologist Stalwart Ajay Mane sir. Then we have sessions like body dysfunction in females, painful bladder syndrome, recurrent urinary tract infection, and types of incontinence. leisure and energy-waste sources in SUI will be dealt by another stalwart, that is Naren Malhotra sir. Birth corpus suspension will be dealt by our own chairperson, Parul sir. So I welcome all of you on this important ICOG certified CME from 23rd to 25th September. All of you are requested to join at the beginning for pre-test, which will be done just now. And after the session is over, please appear for the post-test also, because after receiving at least minimum 50% for getting certificate for all the 3 days is necessary. So just join for pre-test session. If anybody has missed, then it doesn't matter, but for post-test you all have to appear, and for all 3 days session you have to appear for post-test, and at least 50% marks is necessary for getting ICOG certificate course. So in a pre-test you will get the idea about the questions, and in post-test, because all the speakers will speak on that topic, you can confidently answer the questions. So thank you all, and I welcome and I request to start the session. So coordinator, Dr. Meera Raghavan is here. She is from Chennai. Meera. So
hello, ma'am. Namaste to everyone. Can you hear me?
Yes, ma'am.
Yeah. Can we post the link, madam, for the...
Nilima, can you, yeah.
Can we post the link and start the timer, please?
We have 10 minutes for everybody.
Yes.
Suman madam, Vidya Thubi madam.
Bolo.
So yeah, question. So I welcome you all. So I missed just, I have to say only a few words and for 5 minutes only.
Questions in pre-test only, the questions are there, so don't worry. Questions, when they will scan this, they will get the questions.
Okay.
And it is there in the chat box also. If they cannot scan, no, there is a link. They can just click the link and start.
Yeah.
There is a link in the box, chat box. You can click.
Okay. Let me check. Yeah, there is link.
So I think somebody is asking for the link.
It is in the chat box.
Hello.
So it's in the chat box.
It is so clear in the chat box.
Madam, this link is not opening many times. I've also tried so many times. So just now I got another link, then it works.
Oh, it's working. It's working. Checked.
But yeah, it's taking time. Yeah, it's open.
I think time is 5 minutes. Okay.
There is a timer.
Yeah,
So
yeah.
only 5 minutes.
4 minutes,
It's showing.
4 minutes, 40.
Okay.
Where is the timer? Yeah, upper mein timer.
Yeah, ऊपर में.
I can see now.
Madam, those who are left can join for post-test, Vidya madam, because now the link will not operate, right?
Yes, yes.
So, Dr. Meera, you start. Ajay Rani sir has joined, then it's all right. Otherwise, you can call second speaker.
Madam, Dr. Parul sir has joined. For welcome, you just.
Okay.
Yeah,
Okay. We can
welcome.
take blessings from him. Okay.
Yeah.
Can we have Dr. Parul's CV? Yeah. So can I, Dr. Kavita?
Yes, yes, madam. Yeah. Welcome, madam.
So good
Suman
evening,
madam, chairperson
everybody.
Vijayana Surgery Committee, introduce Parul sir.
Yeah. So good evening, everybody. Thank you for this opportunity, dear Kavita. It's a great honor for me to have the opportunity to introduce ICOG Chairman, Dr. Parul Kottawala, sir. As we all know, he is a profound scholar and a great academician, and above all, he is a great human being. Presently, he is professor and head of department of obstetric and gynecology in the Sai Institute of Medical Sciences at Ahmedabad. He is an endoscopic surgeon as well as a consultant gynecologist. And there are so many awards and accolades to add feather to his cap. Welcome, sir. Kindly bless our webinar today. Over to you, Dr. Parul, sir.
Well, thank you. I'm sorry that I was busy with emergency cesarean and I got delayed. Incidentally, I had to get both the uterines. It was a diabetic patient with hypertension, and I had to do that. Anyway, that is why I got delayed. But of course, I welcome you all, and this is a signature program of ICOG. Every time we reach up to 800,000 colleagues joining up, and I'm sure that this program this time also will be as popular as always. And prolapse is a very important topic, and I'm sure that all of the colleagues will benefit from it. So let us get on with the program.
Thanks.
All the best.
Thank you, sir. Over to you, Kavita.
Yes. So, Dr. Meera. Dr. Meera, can you share CV of Dr. Meera? She is coordinator of today's program. Yeah, she is secretary, Chennai Menopause Society, executive committee member, OGSSI. So now I request to invite the speakers. If Ajay Rani sir is here, then he will start his talk. Otherwise, we can go for second talk. So, Meera. Dr. Meera.
Who is the second one?
Yeah. So,
Second
just
speaker?
to, Dr. Meera, please start sharing.
Yeah.
Introducing the chairpersons of first
May
session.
I now invite our chairpersons for
Here,
the session?
Dr. Ajay is already here. So maybe.
Okay, all right.
Hi, Ajay.
Yeah. Dr.
hello,
Mandagini
Jai sir.
Naik, who does not need any introductions, Chairperson ICOG FOGSI 2020-21, President's Association of Medical Women in India, Central Council, various accolades in leading positions, presidents of many societies, and member of various prestigious societies, accolades with awards of various nominations, and delivered lectures and orations in several international national conferences. Welcome, Dr. Mandagini Naik, madam. Thank you very much for being here. Dr. Sadhana Gupta, again, co-chair, SAFOG NCD Committee, FOGSI representative to SAFOG, and Vice President FOGSI 2016, and ICOG Governing Council member and Best Governing Council Award for 2021. Individual awards of Dr. APJ Abdul Kalam Life Achievement Award, various academic publications and awards, including Best AICOG paper, and organizing chair and secretary of conferences in multiple conferences nationally as well. Welcoming Dr. Chitra Madam from Trichy, founder and director, Janani Trichy Fertility Center, founder and director of Lalita Nursing Home, and a passionate teacher who's had a post-graduation from Manipal University, secretary, Indian Fertility Society, South Tamil Nadu chapter, Organizing Secretary for EndoMedCon, patron of TNFOG, and past President TRIOPS. Welcome, Dr. Chitra ma'am. Welcoming Dr. MC Patel, consultant obstetrician, gynecologist, and medical legal counselor who does not need any introduction in this particular niche specialty. Organizing Secretary, ICOG 2017, Chairperson, Ethics and Medical Legal Committee, FOGSI 2011 to 2013, and President, Ahmedabad Obs-and-Gynae Society 2010, Honorary Surgeon, Indian Red Cross Eye Bank, collected more than 1,000 eye pairs. So very prestigious chairpersons to chair this particular session. May I request Dr. Mandakini May to welcome and introduce our first speaker, Professor Ajay Rane. Professor Sir Ajay Rane. Thank you, sir.
So I think good afternoon, everyone from Mumbai. Greeting from Mumbai, and extremely happy to see the. Am I audible? Am I audible?
Yes, madam.
Yeah. So I'm extremely happy to see the growth of the certificate courses which we have started in my period, because there was a COVID, and that COVID has become a blessing for us. And you can just, Parul has mentioned, now it is, increasing by leaps and bounds. So I'm extremely happy. Also, I want to thank the organizer and Dr. Kavita, Suman, everyone here. I can see Charmina, Sadhna Gupta, heartiest congratulations, Meena Samant, Aruna Jha, everyone. And it is my proud privilege to introduce Professor Ajay Rane, whom we really, really admire. And I'm especially moved by his lectures when he talks especially about the fistula, and that, that presentation brought tears in the eyes of the, viewers. So I think with this introduction, I'll start. He is known to all of us, Indian and national and internationally. He is the director of urogynecology, Townsville Hospital, professor and HOD of the James Cook University, chair FIGO Fistula Committee, where I was talking when I heard him in many FIGO conferences, board member of Australian Gynec Endoscopy Society. He was awarded Order of Australia 2013, very prestigious work in the women's health, and finalist for the Australian of the year 2012 award was the Pride of Australia, so prestigious 2019. And he's a filmmaker. He has made this riwayat against female infanticide. I think the topics which he deals is very close to all of us. And innovator for the this PEGI, what is this PERIGI, and philanthropy, Dignity Foundation, Sanitation India, Flourishing Women in Pacific. Academic, he is a great academician, written 6 books and so many chapters, and he got a beautiful family. So, Professor Ajay Rane, we are very eager to listen to you. And
Thank you.
Hello, yeah.
Yeah, I think, so first of all, thank you for the invitation. I'm looking at all these chair people and I thought, oh my God, there's a lot of pressure here for me. But thankfully the talk is only for 15 minutes. So I think I'll bear the pressure and kick on. 8:45, absolutely spot on. So congratulations to the organizers. Spot on 15 minutes. I'll start sharing my my slides. So I hope you can see it. Oh, this is not good. Hang on. So here we go. What's going on? Apologies, give me 1 second. Something is not good here. Let me go share. Are you, the admin is going to allow me to share? Yes, you are. That's very good. Can you see Obama here?
No.
Yes, sir. Yes,
Yeah.
we can see
Good.
you.
As long as you can see Obama, then everything is good. Okay, good. So my topic is assessment of genital prolapse. So it's a slightly smaller topic than what I spoke before. Mira probably gets me to talk every week, but that is the sort of power she has over me, Mira. Anyway, So I think it's important to know that this man obviously is famous, the one next to me, not me, but he's also a husband and a father of 2 daughters. So he understands what is the potential of female pelvic disorders. 65% of women globally suffer from pelvic function disorders. Most of them suffer silently. And that is one of the reasons why I like giving talks, because prolapse or incontinence never kills you physically like cancer, but it kills you every day from embarrassment. And that's why it's very important for us to understand that women need to be encouraged to come forward to volunteer their pelvic floor dysfunction. You will never do pelvic floor dysfunction very well unless you know your anatomy and physiology. So I'm going to spend the next 3 minutes talking to you about why a urogynecologist does what he does. So I did my OBGYN in Pune in BJ Medical College, but then I realized I had to do urology, which is very important because we look after the lower urinary tract in the women. But also I realized that we needed to do gastroenterology for the rectum and the anal canal. So I did gynecology, general surgery and urology, and colorectal surgery. So a long training program if you really want to care for women who have global pelvic floor supports. One of the works that I do all over the world at the moment is gender-based violence, usually victims of rape. And they are traumatized in all 3, the vaginal area, the urinary area, and the anorectal area. So you need to know your anatomy. If you learn only this slide, that's all you need to learn, okay? So the vagina is divided into 3 levels. The upper 4 centimeters of the vagina is called level 1, and it is supported by ligaments. Ligaments are very strong, so they make your organs immobile. What do ligaments support? They support uterus. And if you are busy taking out uteruses, nowadays, hopefully not so much, then you will actually realize that you will get uterine prolapse, vault prolapse, or enteroceal. But the most important thing to understand that level 1 defects are usually asymptomatic. And that's why you have extremely big procedentures. And you say, what? Why did you let it get so big? Because it doesn't bother the woman too much. Level 1 is important because it has to hold the uterus. The uterus has got a non-pregnant capacity.
1 minute,
3.
the slides are not visible, sir.
They're not?
Yeah, the black bar is coming.
Oh, yeah. So there will be a little black bar. I'm sorry. Is it really that bad? Is it very bad, or you can't see at all?
Sir, last row is, yeah, now it's visible.
I
but
will move it. Don't worry.
Yeah, thank you. Please
So,
improve it, sir.
yeah.
There is, yeah, from the.
So what I can do, the only other thing I can do is, what can I do? I can't do anything more. Just bear with me.
It's okay, Ajay. We are listening to you, so that should be fine.
So
These
I
are
think the
prompts
other,
for you, not for us.
the other important thing to understand that the level 2 of the vagina, which is the middle third of the vagina, is 3 centimeters long, and it has fascia as its support mechanism. Fascia allows an organ to expand and contract. Your bladder has to expand and contract 3, 4, 5, 6 times a day. Your rectum has to expand and contract maybe at least once a day. So if you have had ligaments in the mid-vagina, that would not work. You have storage organs in the mid-vagina. So mid-vagina, anteriorly you have bladder, posteriorly you have rectum. It is supported by fascia. Fascia in the anterior compartment shaped like a hammock. Fascia posteriorly shaped like a bed sheet. It goes from one end, uterosacral, and inserts itself into the perineal body. So if you have a break in the fascia, you will get a cystocele or a rectocele. These are prolapses of the mid-vagina, not the distal vagina. We'll talk about distal vagina in a minute. So they will complain of bulge, but they will also complain of urinary symptoms. So if you have a cystocele, a woman will say, I can't empty my bladder properly. I've got recurrent UTIs. If a woman has a rectocele, she goes, I've got a bulge, but I have to insert my fingers in my vagina to empty my bowel. So women with mid-vaginal disease will present earlier because they have symptoms of recurrent UTIs or not emptying their bowel properly as compared to level 1. Now, level 2 is storage. Now, if there is storage, you need to have a tap. So you need to have sphincters. So distal third is all about sphincters. And sphincters are muscular. You have muscles. You have the rhabdosphincter near the urethra. You have the perineal body. And you have the external and internal anal sphincter of the anus. So very important to understand how beautiful this design is. You have ligaments, you have fascia, and you have muscle. So if the defect is in the lowest third in the vagina anteriorly, you will get stress incontinence because the tap is broken. So if the tap is broken, you will get incontinence. If the perineal body is broken, which can happen with childbirth, you will get sexual dysfunction. Women will complain of vaginal looseness. They feel that there's not enough sensation when they have intercourse. And finally, if the external and internal anal sphincters are broken, then you will have flatus or fecal incontinence. So you see, every single prolapse pelvic defect has a unique complaint. So you can't say that this patient has a mild cystocele. Doesn't work. Does she have a bulge? Does she get recurrent UTIs? Does she have incomplete emptying? Oh, she's got a level 3 defect. Well, does she have stress urinary incontinence? Does she have sexual dysfunction? So every single level has its own unique set of complaints. Very important when you're assessing a patient for so-called prolapse. So make sure that you have got all the symptoms lined up next to the defect so you know exactly what's going on. So always correlate with the anatomy. Level 1 is the cervix long. It's long when the uterosacral ligaments are not broken, they're stretched. The cervix is short when the uterosacral ligaments break and you get total uterine collapse, not prolapse. Level 2, you have bladder symptoms, recurrent UTIs, rectum symptoms, manual digitation. Level 3, you have incontinence symptoms, either fecal, flatus, or urinary, and sexual dysfunction. So very important, if you're going to assess prolapse, you need to know the symptoms of the patient. For that, you need to listen to the patient. You have to listen, not talk. Listen to your patient. Ask them about BBS. I always say ask about bladder, bowel, sex. Ask them these questions if you want to, but listen to the patient. Look with your eyes. What is the prolapse? What can you see? Can you see incontinence? Use your hands to examine the patient. And always examine the patient at maximum Valsalva in the dorsal position. No lithotomy, no standing, no squatting. 95 to 98% of prolapses can be seen very clearly just using your hands at maximum Valsalva. Coughing is no good. Coughing is for incontinence. Pushing down, bearing down is for prolapse. Cough for incontinence. Pushing down at maximum Valsalva is actually what you want to do when you want to assess a patient. If at maximum Valsalva, a bulge comes to the hymen, that is called a stage 3 prolapse. That stage 3 prolapse and stage 4 coming out of the hymen are the only two significant prolapses in the history of management of prolapse. So don't say mild anything. If you say mild, that means it's either stage 1 or stage 2. You can use this very complicated system like POPQ. I do not recommend it unless you're doing research. More importantly, is listen to the patient. What are her symptoms? And then at maximum Valsalva, you part the labia, ask it to push really hard, see what is coming out, and that will tell you what the prolapse is. A lot of people say, oh, will you do urodynamics with 95% of patients with prolapse do not require urodynamics. If they have complex urinary symptoms like associated incontinence or associated urgency frequency that makes the picture a bit more complex, you may want to do urodynamics. What I, however, recommend very strongly is a transperineal ultrasound. Everybody's got an ultrasound machine in their clinic. So use the same abdominal probe, cover it with the glove, put some jelly on it, and then put it in between the labia, and you will start seeing the whole world of pelvis. You will see urethra, bladder, vagina, anorectal angle, rectum. It's upside down, but the more transperineal scans you do and ask the patient to bear down, the more you will learn about what type of prolapse it is. Very simply, this is the mantra. She speaks, I speak, she speaks again, and then we decide. So decision-making is where you give the patient 2 opportunities to speak. Your job is not to speak. Your job is to listen. First, let her speak, then you can speak, then she speaks again, and then we decide. What will you decide when the patient says, doctor, what do you think I should have done? Because 70% of your patients will say, so what do you think I should do? When you get that question, the answer is very simple. Apply the mother test. What will you recommend to your mother? The answer is always correct. Mother-in-law may be a different issue, but mother test will never fail. So if a patient says, what do you think I should do? Say, what would you do to your mother? And that's very important. So the decision making is she speaks, I speak, she speaks again, and we decide. A lot of people tell me we do not read textbooks anymore. If you feel like reading a textbook, this is a simple textbook written by Tamir Selvi and myself. We're nearly ready for the next edition. But assessment of prolapse is simple. You check the level, you check the symptoms, you check the stage by examining the patient at maximum Valsalva. She speaks, I speak, she speaks again. Apply the mother test, and it's done. So simple. So remember, simple. Check the level, check the symptoms, check the stage. At maximum Valsalva, she speaks, I speak, she decides, and then apply the mother test. Thank you very much.
Hello. Hello, Vidyatri madam. Yeah, thank you, sir. Thank you so much. Please, chairperson, Sadha madam.
Thank you very much for explaining in such a beautiful way. And I think all our,
Patel, sir.
viewers must have been really very clear in the mind, Ajay. You are so good all the time that we learn. And one thing which I have observed this time is you got all the 3 surgical skills which normally as an obstetrician we do not have, like urogynecology, then your gastroenterology, because whenever there is any injury to we just rush for the
And there is nothing wrong with that. I think if you decide to give your life up for looking after women who have all these combined injuries, especially when we deal with women of rape or such injuries, then we need to be good at all of those things. Yeah.
I think that makes you stand apart from all the gynecology, and that is how we really admire your surgical skill. And we will try to learn as much as possible along with all our, the delegates. So thank you very much for that excellent lecture. And
Thank you so much.
Sadhana madam and Ms. Patel sir in one sentence.
Thank you, Dr. Ajay. Always a treat to listen to you. And actually, it is you said that is stage for a teacher. Because we are turning, you say how to use your senses, and that is a very important issue especially in the young people of our country and I think globally, and making complex things simple. Somehow the teaching has become now the making simple thing complex. And the Indian College of Obstetrician Gynecologists is really aimed that we make the complex things simple, easily understandable and easily doable by it. So thank you very much for your presence, and we look forward to more and more association and listening to you. Thank you.
Thank you.
Meera? Yeah. Dr. Meera, are you there? Okay.
Kavita ma'am, you
So,
can go
yeah.
ahead.
May I introduce
Yes.
Achla? May I
Yes, ma'am.
introduce? Yeah.
Yeah, MC Patel sir, please introduce Achla madam. Okay.
MC,
Vidya madam.
you need to unmute yourself, and if he cannot, maybe the technical help can be given to him. MC, unmute. Now it
Yes, no. Actually, host was not allowing me to unmute.
Okay.
Oh, they are very stringent.
So, no issue. So, I have to introduce Dr. Professor Achla Batra. He is National President, NARCHI 2022 to 24, Governing Council Member, FOGSI ICOG elect, Chairperson, IHCP Division Stillbirth Society of India, Member of FOGSI Project on Reducing Cesarean Birth, President NARCHI Delhi 1921, Professor OS GY VMMC and Safdarjung Hospital, more than 40 years experience, and reviewer of international and national journal, and to cut short, past president of AOGD and good orator always. So may I please request Dr. Achla Batra to take over the subject. Anatomy of...
Thank you, Dr. Patel,
Yes.
for your kind introduction. And after Dr. Ajay Rane explaining everything in such a short time, I don't know what I am going to do, because anatomy of urogenital system, half the things is already talked about. But of course, we all have to know, have a comprehensive knowledge of urogenital anatomy so that we can operate safely, maximize exposure, ensure hemostasis, and avoid injury. This is what is already shown, the orientation in pelvis, bladder, uterus, rectum. So I will be mainly concentrating on anatomy in relation to prolapse and little bit on SUI, because in 15 minutes can't do everything. So we have pelvic bones, which form a support for the pelvic organs by giving attachment to the various fascia and muscles. And
Madam, you want to share your slides?
yeah, you can't see them?
No, madam.
I already shared.
First open the PPT and then share.
Madam, click on share screen and then select the PPT. Yes, it is open. Yeah, make it slideshow.
So the pelvis is like a basin with posterior wall, sacrum, laterally piriformis, side walls, obturator, and floor by the levator. We have certain landmarks of the bony pelvis which we must know. Ischial spines, where the sacrospinous ligament attach. In paravaginal pairs, we can palpate it to identify the location of the lateral vaginal attachment. Pudendal block is given here. The pubic arch to know whether a hysterectomy can be done or not. The obturator foramina, very important, through which obturator vessel and nerve pass, covered by obturator membrane, and transobturator slings are passed through the obturator, and there is on the superior lateral side of tunnel through which the nerve and vessel bundle is passing. So one has to know that the safe entry zone is on the medial side. Then we have pectineal line on the superior side, where it gives attachment to pectineal or Cooper's ligament, which we use in Burch-Kolper suspension. Sacral promontory, very important part of the pelvis, where the pelvic anatomy begins with bifurcation of common iliac artery, ureter crosses from lateral to medial, and the superior hypogastric nerve plexus unite to form the nerve. The pelvic viscera lying in a orientation in such a way that they are supporting each other. And the main support of the pelvic viscera is fascia and ligament, and it is resting on the pelvic floor. It has 3 compartments. For sake of convenience, we divide anteriorly bladder and urethra, middle uterus, cervix and vagina, and posterior rectum and canal and anal sphincter. This is orientation you see. The endopelvic fascia, the pelvic diaphragm, and the urogenital diaphragm, they support the pelvic organs. The urogenital diaphragm is only present in the anterior and middle compartment. And this you can see endopelvic fascia, the pelvic diaphragm, and the urogenital diaphragm. The endopelvic fascia is parietal, visceral, or deep endopelvic. So what does is the fascia is covering the viscera. So it's named after the viscera. Then we have parietal pelvic fascia, where this fascia is getting connected, and in between we have a endopelvic connective tissue. So we have a kind of tube from the top at the pericervical rim till the levator, in which we have the visceral fascia, we have the endopelvic connective tissue, and the parietal pelvic fascia. The parietal fascia is obturator internus over levator and eye, piriformis, and presacral. What is very important to understand arcus tendinous fascia levator line. It is a thickened portion of obturator fascia. Anteriorly, it is attached to the pubic raphe and posteriorly to ischial spine. And it gives origin to iliococcygeus muscle. This is where it is. Then arcus tendinous fascia pelvis, which is the main support of the lateral support of the vagina. The endopelvic tissue of vagina gets attached to it. It is a condensation of obturator fascia and the visceral fascia. They both join together to form a condensation. It runs parallel to the arcus tendinous levator ani that you can see. The arcus tendinous fascia levator is lateral and the fascia pelvis is medial. Anteriorly, the same attachment, pubic rami, and posteriorly joins the arcus tendinous levator ani. This you can see the various connections of the fascia. So, like I said, that the organs have fascia which are named after the organ, and they form ligaments at places. So in urethra, they form, around urethra, they form the pubourethral ligament, the paraurethral ligament, the periurethral ligament. Around bladder, they form the pubovesical and the pubocervical. This is anteriorly. Uterosacral ligaments is also a condensation from posterior part of the cervix to sacrum. Cardinal ligament is condensation from the lateral to the side walls. Pubocervical fascia is forming a full sheet from the pericervical ring till the levator and is supporting the anterior vagina. And the lowermost portion of the pubocervical is present like a hammock below the urethra, and it in conditions of increase in the intra-abdominal pressure, this hammock presses the urethra and prevents incontinence. Then we have the rectovaginal septum posteriorly from one ischial spine to another. Inferiorly, it is attached to the perineal body and above to the pericervical. So we see all the fascia, they are attached to a pericervical ring superiorly and levator and perineal body inferiorly. Presacral fascia is a parietal layer of pelvic fascia, which is located posterior to the retrorectal space. It is very thick and strong. Many veins, arteries, and nerves reside, and we use it for sacrocolpopexy. The other support is pelvic diaphragm. It is made up of levator ani and coccygeus muscle. Levator ani has 3 parts: iliococcygeus, puborectalis, and pubococcygeus. And piriformis is the lateral wall. Puborectalis forms the sling around the anoradical junction, inserting into the superficial and deep part of the anal sphincter and proximal part of the internal sphincter. So it helps in maintaining continence by contraction. Pubococcygeus from the inner surface of the pubic bone to vaginal wall, and to intersphincteric groove between internal and external anal sphincter. It supports the posterior wall of the vagina, elevates the anus, and keeps the urogenital hiatus narrow. Iliococcyges from ALTA and ischial spines, and the fibers unite behind to form an anococcygeal raphe and levator plate. And it forms a horizontal shelf on which the upper vagina and cervix rest. Anteriorly, there is a hiatus between the puborectalis and pubococcygeus for passage of urethra, vaginal, anal canal. And posteriorly, we have the levator plate. So normally, when it is not damaged, it is horizontal. But if it gets damaged, then it becomes vertical, and the urogenital hiatus flags, and there is predisposition to prolapse. Levator ani has two kinds of fire: slow twitch, which maintains a tone all the time, and a fast twitch fibers. When you have increase in the intra-abdominal pressure due to coughing or sneezing, then these fibers contract, and you can see, if you try it now, it will raise your pelvic floor up. Below the pelvic diaphragm is perineum, which has superficial and deep muscle. Superficial muscle, we all know, bulbocavernosus transversi. Then we have the ischiocavernosus. Then we have a perineal membrane anteriorly. And then we have deep compartment, which mainly has related to urinary incontinence containing the compressor urethra and the urethrovaginal ligament. It is present in the lower 1/3. Then we have the perineal body, which is formed by condensation of bulbocavernous anteriorly, transverse laterally, anal sphincter posteriorly, some fibers of levator ani. The perineum stabilizes the lower pelvic floor, and it is attached to the pelvic wall by the trans. Like Dr. Rani said, when you have damage here, then there is widening of the introitus, and interiorly, if there is a damage in the pubocervical fascia, then you have incontinence. So nerve supply is by S2 to 5, and pudendal nerve does not take part in the levator innervation. The rest of the pelvic floor is supplied by the pudendal nerve, and internal iliac vessel, hypogastric nerve, and pelvic splanchnic nerve supply bladder and rectum. Then already Dr. Rani has talked about the level 1, level 2, level 3 supports. So I need not talk about it. Level 1 is uterosacral and Meccan rod. 2 is endopelvic fascia. 3 is levator ani and the perineal muscles. And what happens if there is a damage? Level 1, there is prolapse of uterus, post-hysterectomy wall prolapse or enterocele. Level 2, cystocele, rectocele. And level 3, urethral hypermobility, rectocele or lax perineum. Then we already talked about this, so need not talk about it. So this you can see, if there is a level 1 defect, the cervix comes out. If there is hysterectomy, the wall comes. And this is a defect in the transverse part of the anterior pubocervical fascia. So there is a cystocele coming from the center. So these are the kind of defects you can have, central when there's damage to the center, lateral when you have damage between the white line and the fascia, and you have the transverse defect when it is detached from the pericervical ring. The cystocele and urethrocoele if you have defect at the level of the urethra. Then posterior compartment, again, Dr. Rani has talked about it. So we have level 2 posterior vaginal prolapse and level 3 rectocele or perineal. Pelvic ligament, we have sacrotuberous, sacrospinous, anterior longitudinal Coopers. Why they're important? Because we use them for fixation. Sacrospinous goes from the ischial spine to the lower part of the sacrum. It's a strong ligament covered by the coccygeus muscle. And the importance of knowing anatomy is that you should not go below the ligament. You should go through the substance of the ligament when you are doing sacrospinous, because above it is the sciatic nerve, and you should be medial to the ischial spines, because just below the ischial spines, we have the pudendal nerve vessels. So you have to take care when you are doing wall suspension. Uterosacral has 3 parts, and ureter remain lateral to uterosacrals, but in the distal part, they are 2 centimeter, and intermediate part, which is used in the high uterus, they are 4 centimeter away. So this you can see that the ureters are a little away. So you take the bites through the uterosacral starting just above the ischial spine, but you should always keep the ureters in vision, and after the high uterosacral, do a cystoscopy to see if you won't enter, because you will be taking through the substance, but you can kink it. Ureter can be injured during gynae surgery, And you should always keep in sight at the pelvic brim. You can injure it by clamping the infundopelvic, at the isthmic region when you are ligating the uterine vessel, at the vaginal apex when you are clamping or suturing the cuff. And it can happen in uterosacral ligaments 11% and interior repair also 2% cases. The nerve supply of the pelvis is hypogastric nerve and pelvic splanchnic nerve, sympathetic and parasympathetic. And then we have some spaces in the pelvis, very important, which we use to dissect, especially in cases of distorted anatomy. So we have the pubovacical ligament, lateral to do is the paravesical space. Before it is the space of Ritzius. Then we have the cervical fascia, we have the rectal fascia and the space between them. Then we have the retrorectal space. So these spaces, they help us in dissection. This we all know how we dissect the vesicocervical space. And the prevesical is used for Bursch Kolper suspension, but you have to be careful that don't go lateral because you can damage the venous plexus of Santorini and the nerves. So just remain little medial. Then you have paravesical, which you can use if you don't find uterine, you can use this space. Then we have pouch of Douglas. We know all about it. Rectovaginal septum, we already talked about it. Presacral, very important space because here we are putting the Kolper suspension. So you have to know that right side is right common artery and ureter, left side is left common artery ureter. It contains middle sacral vessel, superior hypogastric pelvis, and origin of hypogastric nerves. So you have to be careful when you are taking the putting a mesh and taking the stitch from the anterior longitudinal. Then a word about anatomy of bladder and urethra. We all know bladder has the detussus muscle, which, it's a globular structure and it has a detussor muscle, which doesn't change pressure even on distension. And below that, we have the urethra. And the urethra has internal sphincter as well as external sphincter. And the external sphincter is what is supported by the hammock, which is formed by the pubocervical fascia inferiorly. And then there is alteration in anatomy, incontinence can occur. So supports of the urethra are extrinsic, which are levator and endopelvic fascia and the arcostendinous fascia pelvis, because the fascia is attached to the arcostendins and to levator and sphincter. And intrinsic are the muscles, the tone, and the elasticity. So knowledge of the functional anatomy of the pelvis is crucial for gynecologists. It helps in identification and management of pelvic floor. Because if you want to conquer a land, you should know it inch by inch so that you can tread on it even with closed eye. So we all must first know anatomy before we start practicing urogynecological surgery. Thank you.
Thank you, Dr. Achila. And again, congratulations for covering the subject very nicely, touching the very basics of anatomy of pelvic floor and urogenital system. And you have very nicely mentioned not to end up into any injury to any vital structure, either vessels or any nerve supply. So it is very important to know basic anatomy to deal with any surgery or so. You have very nicely mentioned as far as levator and is concerned, go through substance and not the below. So not to end up into injury to nerves. You have mentioned also not to end up into ureteric injury at the time of sacrofixation. If you are higher, it's fine, ureter is far, but as you go down, it is nearer one and you should be conscious one. So thank you, Achila, for the same.
Thank you, Dr. Achla. It was really compilation of very, very complex subject. And actually why this is very, very important, like the Homo sapiens, we start standing and we start walking on two legs, then the childbirth, and then the estrogen deficiency and the postmenopausal, everything, and the sexual intercourse, everything makes a lot of damage. And how the nature has made so much perfection, and it is a complex also. And you have put, what a beauty of your talk was to point out where is the applied anatomy and where are the points that we should be careful. So anatomy is revision, what is looking your land, looking at your operative field, and only that, urogynecology is, I think it is a field where the undo and overdo. It is very, very thin balance, and your talk and Dr. Jairani's talk will really set the stage for the further diagnostic procedure and the operative procedure. So thank you very much, Dr. Achla, for compilation of very complex subject in just 15 minutes.
May I request our next chairperson to introduce our speaker, Dr. Jessima, Dr. Sadhana Gupta, Dr. Chitra.
Can I take the privilege of introducing?
Please, madam. Thank you.
Dr. Jessima Subani is an urogynecologist as well. She has completed her MBBS from Madurai and did her DJO from MMC. Again, her surgery from Stanley and MCH Uro from Stanley as well. Now, she has been working as a female urogynecologist for years, and she's specialized over overactive bladder, and she's been in charge of IUGA alumni meet at Nashville. She has presented papers there, I guess. And we are waiting to listen to you, ma'am. Over to you.
Thank you, ma'am. Let me start sharing my slides. I thank ICOG for the opportunity at the onset. Is my slide visible, ma'am?
No, ma'am.
No.
First open the PPT, then come to Zoom screen, and then share.
You have not started sharing only.
Team ICOG, please allow her to share. Sometimes that is missed out.
She is already posted.
You can log out and re-log in. Sometimes that happens.
Yes, sir. Kindly give me a minute.
Yeah, we can see.
Yes, ma'am.
Just make it full slide. Yeah.
Yes, good. Good evening, everybody. Coming to the neural control and the pathophysiology of micturition. A normal bladder function is characterized by the storage of adequate volumes of urine at low pressures without leakage and without unwanted bladder sensations in the form of urgency, which is interspersed with short time periods of efficient and unimpeded expulsion of urine. For this to happen, it is a complex process which involves the central nervous system, the peripheral nervous system, and the lower urinary tract structures, which requires a coordinated interaction between all these for a proper bladder filling as well as emptying, and also to maintain the continence and to prevent urinary tract damage, that is the damage of the kidneys. Saying this, the CNS acts like a switch between elimination and storage. Storage is the predominant function. Our bladder remains in a storage phase for around 95% of the time, and only remaining 5% of the time we use the bladder for a voiding purpose. But the central nervous system acts like a switch between these two functions, coordinating between the urinary bladder and the urethral sphincter. The components of micturition control consist of the central nervous system, which includes the brainstem containing pons and medulla, the spinal cord containing thoracolumbar and sacral level segments, and coordinated by the cerebrum above. So the peripheral nervous system consists of the sympathetic nerves in the form of hypogastric nerve, the parasympathetic nerves in the form of pelvic splanchnic, and the somatic nerve in the form of pudendal nerves. The lower urinary tract structures consist of the bladder, the detrusor muscle, and the urethra in the form of the internal and the external urethral sphincters. An overview of the nerves involved in micturition include the sympathetic nervous system arising from the segments T11 to L2, thoracic 11th segment to lumbar 2. The nerve is the hypogastric nerve and it promotes urinary storage, whereas the parasympathetic nervous system arises from segments sacral segment 2 to 4, traverses along the pelvic nerve, and its function is to initiate bladder empty. The somatic nervous system also has a role in the form of it originates from the same segments S2 to 4, and the nerve is the pudendal nerve, which functions in controlling the external urethral sphincter in a voluntary basis. This picture shows the various levels from which the sympathetic and the parasympathetic fibers arise. We can see that the sympathetic fibers, the ganglion, are placed close to the spinal cord, whereas in the parasympathetic system, the ganglion, the relay in which the nerves relay to form secondary neurons, they lie close to the organs. Coming to the afferents, there are two types of fibers from the bladder that detect the stretch: the A delta fiber and the C fibers. The A delta fibers are they are myelinated fibers. They conduct little slower. They have organized conduction. They have low threshold and short duration spikes, and they have tonic firing. Whereas the C fibers, usually they don't take part in much of conveying stretch unless in conditions of inflammation and infections when they are exposed. As we see in the previous picture, the C fibers come even up to the level of the epithelium. So these C fibers, they are having high threshold and they do have phasic firing, and they are sensitive to capsaicin. These two fibers relay the constant filling sensation, especially the A delta fibers relay the constant filling sensation to the spinal cord. Coming to the motor receptors, the receptors involved are the adrenergic receptors and the cholinergic receptors. In the adrenergic receptors, we have the alpha receptors, which are found in the bladder neck, alpha 1 receptors, which promote bladder neck closure, and the beta 3 receptors, through which the hypogastric nerve acts using norepinephrine. These beta 3 receptors, these are found in the detrusor muscles, and that facilitate relaxation. Together, these two help in storage. Coming to the cholinergic receptors, these are the M2 and the M3 receptors. The M3 receptors present over the bladder help in stimulating the detrusor, promote M2 and M3, they help to promote in voiding. Other receptors, they also secrete ATP and nitrous oxide, which at present are being told in conditions like chronic inflammations of the bladder and in interstitial cystitis-like conditions. Coming to the phases, we have the storage phase where there is a sympathetic dominance, the bladder is relaxed, and there is urine storage. And a voiding phase where there is a parasympathetic dominance, the bladder contracts with the relaxation, with the coherent relaxation of the urethra, and there is a urinary release. What is the role of the spinal cord? The pontine micturition center is involved in controlling and coordinating the bladder contraction and sphincter relaxation, wherein the cortex comes in to inhibit the pontine micturition center to go ahead with volitional control. It says when and where to void. Even if the bladder is full, when and where to void is better decided by the cortex. And the basal ganglia and the thalamus also modulate the bladder control pathways. Coming to volitional control of micturition. What is volitional voiding? The conscious control over urination via the cortical inhibition of the bladder reflex is known as volitional void. This is through the external urethral sphincter control. This is maintained by the somatic nervous system, namely the pudendal nerve. So the pudendal nerve also takes over the guarding reflex, which means is an abrupt increase in the striated sphincter activity, which is seen with a cough or an increased abdominal pressure during a normal bladder filling phase or a storage phase. This is like when we cough, the external urethral sphincter does a more Pinchcock effect so that it doesn't allow to leak. This is maintained by the presence of the intact pudendal nerve. The gateway mechanism for this lies in the on-off nucleus, which is also present at the same S2, S4 segment level, but a little anterior to the parasympathetic nuclei, and it functions to have its function is to have a voluntary control. This picture shows the different nuclei at the different levels. The most important one I want to highlight is the sacral spinal cord, where the on-off nucleus and the sacral parasympathetic nucleus lie at the same level, but they are involved in different functions. Coming to storage. One, there is a stretch reflex. It is sent all along the sacral cord to the through the ascending spinothalamic tracts, through the thoracolumbar, to the pons and to the higher centers. When there is facilitation or inhibition is decided by the brain. When the bladder wants to store, the message is sent from the lateral pontine micturition center, which stimulates the sympathetic neurons as well as inhibits the parasympathetic neurons and interneurons. The stimulation of the sympathetic neurons tightens the urethra. The inhibition of the parasympathetic neurons causes detrusor relaxation, and the stimulation of the somatic neurons also causes the sphincter contraction. All these lead to the closed bladder neck and proximal sphincter. When there is enough signals from the bladder and when the condition is fair enough, good enough, the person gets the right place and time to void, then these same afferent sensations received by the pons switches over to facilitation and the median pontine micturition center takes over. This stimulates the sacral parasympathetic neurons and interneurons and inhibits the sacral somatic neurons and interneurons, which causes the contraction of the detrusor and relaxation of the sphincter. Said this is the representation over urodynamics of what really happens during micturition. The first event to occur is the silencing of the electromyogram. That means the sphincter sensation or the sphincter firing is silenced, the first event to occur. The next is the fall in the urethral pressure. The second event to occur is a fall in the urethral pressure, closely followed by a rise in the bladder pressure. That is, the vesical pressure rises. Having all this, the bladder neck opens and Q means the flow of urine starts. This is how actual micturition occurs. The bladder's circle of life shows that in young age, there is involuntary voiding. And as the tracts mature, it converts to voluntary voiding. Any disease, neural injury, or aging takes the voiding to similar to an involuntary stage. Or when there is a defect in maturation also, it persists with the involuntary neonatal reflexes. Some therapies at times converts and helps to bring back this to the voluntary type of voiding. Coming to the pathophysiology affecting micturition, the common conditions that are involved are overactive bladder, which is predominantly having urgency as the predominant symptom with frequency with or without urinary incontinence. And the cause being an overactive detrusor muscle. There can be urinary retention wherein we have inability to void due to impaired detrusor or urethral function. And then there can be neurogenic bladder, where there can be a spinal cord injuries or neurological diseases like Parkinson's, our own diabetes, and multiple sclerosis, etc. Stress incontinence can also cause a weak pelvic floor muscle or sphincter, and this can also lead to a defective voiding. This is where our drugs act. The commonest drug that is used as is an anticholinergic, which acts, we use in OAB is an anticholinergic, which acts on the M3 receptor. This has a competitive inhibition not to allow the acetylcholine to act, and hence preventing the contraction of the smooth muscle. The word detrusor means, the detrudo means bear down. So the main function of detrusor is to contract and push down urine, which is avoided, which is prevented by relaxation using this M3 receptor. Coming to the next famous drug we use is our beta-3 agonist. Again, here it acts on the adrenergic receptors, promoting a similar action like norepinephrine, causing bladder relaxation. One more drug that is used, used even and commonly in refractory type of overactive bladder, is our monobotulinum toxin or Botox. Here, this botulinum toxin acts in the presynaptic junction. This is the point of action of the drug, wherein it prevents the acetylcholine vesicles fusing and entering into the synaptic cleft. So this is how our botulinum toxin acts. This picture shows the close proximity of our various nerves involved in micturition, namely the parasympathetic, the sympathetic descending from above, the pelvic parasympathetics ascending, the hypogastric plexus, the different pelvic splanchnic and the sacral splanchnic nerves. Any disease and disorder of the disc, any surgeries over these regions can all result in neurological conditions that affect the bladder, causing neurogenic bladder. Thank you. These are my references. Thank you.
Thank you, Dr. Jessima. You have made it clear. Until otherwise we understand the physiology, it is very difficult for us to treat them medically with any drugs. Thank you very much.
Thank you, ma'am.
I would suggest that in between the chairpersons do look up if there are any questions in the chat box. You can pass them on to the speakers.
Yes, sir.
No questions are there in chat box.
Assessment of urology guidelines 2020.
Let us get on with the program.
So I will introduce Kavita. I will introduce Dr. Mandeep Pal.
Please introduce. Yeah.
So great pleasure to introduce Professor Mandeep Pal, and he has been principal COM JNMH Kalyani, West Bengal, a very warm and very knowledgeable person. He has been recipient of IMA Doctors Day Award 2023 from IMA headquarters New Delhi. ICOG visiting professor 2023 and Dean India Academy of Obstetrics and Gynecology 23 to 26. So a wonderful clinician, Dr. Mandeep Pal, and he has authored many books, and we all look forward to a very, very important subject, that is how to assess a woman with the urinary problem. So Dr. Mandeep Pal. I think Dr. Mandeep, you first open your presentation on desktop and then minimize and then join.
Okay. Is it not opening from their side, madam?
We can see your desktop, but not the presentation.
No, actually, I have given it to the ICOG office. I told them to present from their side. Is it getting difficulty to present from their side?
No, you need to tell them. Now office people can do that.
Yeah, please. Yeah, please. Sorry. Please do that.
So Nilima, can you just open up his presentation? Is it there on this? No. What is happening? The screen seems to have frozen.
Okay, then can I just speak on this?
Maybe if you have it on your computer, you can share the screen and get on.
No, sir, that I cannot do right now because I am outside now, but I am doing from my mobile. So from here, I cannot share the screen, but I can speak on this. Shall I start speaking?
Just a moment. Is there, some response from the office? Yes, they will recheck.
Sir, they're trying to open. It's a big file. They're finding it difficult to open. That's all.
Can we change the order
Okay.
and the next person can speak? In the meantime, these people can sort it out.
Yeah. That we can do.
Yes, please let us do that.
I don't mind if I present as well, sir. Not a problem, because I don't know whether the next speaker is there in that order. Monica is there.
Yeah, it's no problem. I'll just wanted to present that one. I'll just speak on it. Okay. There is a technical issues regarding the presenting the slides, but anyway, for whatever I'm going to say you, this is on the European Association of Urology 2024.
Sir, because there will be a
on
post
the
test.
how to non-nicotinic. Given the MCQ already.
No, sir, because there'll be a post test. It'll be better to show the presentation for the benefit of all the attendees. Okay. So that is why it'll be useful. Otherwise, it's very difficult. So Nilima is downloading the presentation. So with permission of seniors, can I go ahead with my presentation so Professor can take up the later slot?
Yeah, I think you can go because by the time I have sent Dr. Mandeep Pai's presentation to office. So Nilima told that she will share. So I think there may be some time, but she will do. So by the time, okay, if Dr. Monica Gupta, because we have to share the chairpersons also. So Nilima, if you can share Dr. Mandipa's presentation, please do it. Otherwise, we will move for second session. Can you do?
The file is very heavy, ma'am. So our
Ma'am,
doctor
I'll
is
go,
getting
ma'am. I'll do the presentation. My slot professor can do.
Okay, okay. Okay, so please start sharing the chairperson session, chairperson CV. So anybody who is from office, please start sharing chairpersons for second session. Yeah. So yeah, keep it yeah, larger. So we are moving to second session. By the time Dr. Mandip Pai sir presentation will be shared, we can go ahead. So Dr. Vijay Lakshmi Sadri madam is very well known, and she is senior consultant of Gani Sundara Medical Foundation Chennai, and her special interest is high-risk obstetrics, midlife issues, and medical legal issues. She has received Asia GCC Healthcare Leader Award in 21, 23, 24. ICOG Valued Contribution Award in 21, Best Paper Award AICOG 2014, and has many publications on vulvovaginal infection, induction of labor, and hirsutism. Next slide. So Dr. Meena Samant, madam is from Bihar. She is senior most member of Patna FOGSI Society, presently president, as GC member ICOG 23-25. FOGSI Clinical Research Committee Chairperson 1922 and Vice President ISOPOV in 23. She was Secretary General ISOPOV in 1822 and has written 10 chapters in books and many articles in national and international journals. Next slide, next CV. So Dr. S. Vidya Prabhakar, Vice President, Tamil Nadu Society, immediate past President, OG Society of Salem, active member of Preventive Oncology Committee, FOGSI, approved instructor ALSO, course by American Association of Family Physician, and MD Ops from MAMC, New Delhi, assistant professor, KMC Manipal, between 1995-2000, and trained in gynae endoscopy, ART training from Singapore. Next. Her special interest is high-risk pregnancy and infertility. Dr. M.G. Dhanalakshmi is professor and senior consultant, Department of Obstetrics and Gynae, Sri Ramchandra Institute of Higher Education Research, Chennai, and she is undergraduate 25, executive committee member of St. Gynae Society, Southern India, 23-24, honorary treasurer, Chennai Menopause Society, 23-25. So now with this, I invite any doctor to introduce Dr. Monica Gupta, madam. Any of Dr. Meena Samanti, are you there? Anyone can introduce Dr. Monica Gupta. She will be speaking on body dysfunction in females.
Yeah, fine. I'm there. I can do that. Dr.
Yeah.
Gupta is from Safdarjung Hall. Can you hear me, please?
Yes, we can.
Thank you. She's from Safdarjung Hospital, New Delhi, and is a fellow of the Urogynecology and Pelvic Reconstructive Surgery. And of course, fully merged into the urogynecology, also has a special interest in critical care obstetrics. She has been very actively involved with the AOGD and of course has been an editor of the ICOG and has also received special awards like Kamini Rao Yuva FOGSI Orator Award and ICOG Travel Fellowship Award, DC Datta FOGSI Awards and several more, and has authored into international and national journals and has contributed to several chapters. And editorial, she's also in the editorial board of the Indian Journal of Obstetrics and Gynec Research, the OGD Bulletin. Of course, affiliated to several bodies, very important bodies of FOGSI in India. So over to you, Dr. Monica Gupta. We are waiting to hear to you.
Thanks for the introduction, ma'am. Am I audible?
Yes, Monica.
Yes, you are.
Yeah, okay. So I'll just quickly share my screen. Can you see that?
Yes. Make it large, full screen.
Is it fine now?
Yes, Monica.
Yes,
Go ahead.
yes.
So, good evening, one and all. I have been given the proud privilege to speak on a very important topic, which is voiding dysfunction in females. And I'll just give a short disclaimer that very nice presentations have been done in the first session. So I will not try to elaborate much upon the basic anatomic and the physiologic aspects. And we'll just quickly rush through those slides and come to the important aspect of proper voiding dysfunction. So the definition of voiding dysfunction, according to the International Continence Society, is female is an abnormally slow and or incomplete micturition based on abnormally slow urine flow rates and or abnormally high post-void residuals, ideally on repeated measurement to confirm abnormality. Now, this refers to a spectrum of urinary difficulties that impact the ability to efficiently and comfortably empty the bladder. Having said that, we must know what are the urinary symptoms with which a patient of voiding dysfunction can present with. They can be voiding, mainly they are the voiding symptoms we are worried about in voiding dysfunction, but there can be an simultaneous overlap of storage functions as well. So voiding functions being, as you can see on the screen, pushing or straining to urinate, spraying stream, weak stream, post-voiding dribble, intermittency, incomplete emptying, or hesitancy. Whereas storage symptoms, as we all know, urge, urgency, loss of sensation of urination, frequency, nocturia, pain or discomfort, or incontinence. Now, why we are talking about the voiding dysfunction at this forum? Because the problem statement is quite large, and voiding dysfunction in women account for around 2.7 to 23% of general population, with a significant impact on quality of life. Mostly, storage and voiding symptoms can coexist and may have different pathophysiology, or they can be related to one another. Now, it can be due to nerve dysfunction or non-relaxing pelvic floor muscle, or both. Amongst the voiding dysfunctions, the voiding symptoms I've just described, the terminal dribbling is the most common symptom seen to the tune of 38.3%, followed by feeling of incomplete bladder emptying, and further followed by weak stream. Now, I won't elaborate much on anatomy, anatomical aspect. This is the the bladder wall cut section showing the histological aspect of the bladder wall, and on the right top side of your screen is the urethral cut section. The only significant point I would like to make here is these presence of submucosal veins and submucosal arteries in the submucosa of urethral epithelium, which are majorly responsible for cooptation of urethra and helps in closure and making the patient continent, and very largely dependent on the level of estrogen in the female. Now, when we talk about voiding dysfunction, it's not complete without talking in detail a bit about urethral sphincters, which help in voiding of the voiding in females. Now, internal urethral sphincter specifically is nothing but a group of circular smooth muscle fiber layer situated at the base of bladder neck, which normally is in a state of contraction, and it's a physiological sphincter, not an anatomic one, under involuntary control, mainly autonomic. Whereas external urethral sphincter, as we say, is made up of skeletal muscles, the circular striated muscle fibers, which surround the urethra at the level of mid-segment mainly, and reinforced by pelvic floor muscle fibers. It is, as we know, under voluntary control, and during micturition, it relaxes to allow the urine flow. You've already dealt in detail about the innervation of urinary system. Just to reiterate, just the central diagram, if you can just ponder upon, that sympathetic afferents to the detrusor are inhibitory and stimulatory to urethral muscle, whereas parasympathetic afferents are stimulatory to detrusor and inhibitory to urethral muscle. So, and this coordination and is very much required to for the coordination of the micturition cycle in the filling and the voiding phase, which has already been beautifully described by the earlier speaker.
So we'll not go in detail, but you all must know to understand voiding dysfunction and to understand incontinence, to understand lower urinary tract symptoms. This understanding of physiology of filling phase and voiding phase is very important. Now, classification of voiding dysfunction in females can be categorized into three major aspects. It can be because of bladder underactivity, it can be because of outlet issues, or combination of both. When we say underactivity of bladder, it may be neurogenic and may include iatrogenic causes, myogenic, the retrusor muscle issues, psychogenic, or idiopathic. When we talk about outlet, it may be anatomical or functional. Now, this obstruction could be because of bladder neck contracture, urethral sphincters, urethral compression, or fibrosis due to previous irradiation and multiple other causes. Whereas functional could be because of striator sphincter dyssynergias. These are very specific terms we use during our pressure flow studies, urodynamic evaluation. Then smooth sphincter dyssynergia or dysfunction, or dysfunctional voiding. We'll come about this a bit in detail in the later aspect. So how do we evaluate a patient of voiding dysfunction? In the history aspect, we must remember that the classical presenting symptoms of such females is usually straining or use of abdominal pressure to initiate or complete voiding with interrupted urinary stream or poor flow. So next time any such patient is coming, keep this differential in mind. Feeling of incomplete evacuation of bladder, or need to sit for prolonged periods on toilet seat, or sometimes need to stand in order to evacuate her bladder completely. And we need to comprehensively evaluate these symptoms in terms of onset, duration, severity, triggering events like, things like infections, urinary tract infections, vaginitis, which are a very important cause of transient voiding symptoms. Voiding diaries, as we all know, probably will be dealt in detail with by Dr. Mandeep once his presentation is loaded. So I deliberately left it over here. Then validated questionnaires, which are specific for voiding dysfunction bother in females, are the ones mentioned here, like Bristol female lower urinary tract symptoms, urinary distress inventory, short form, or the lower urinary, the LURN symptom index 10. Other historical aspects in this evaluation would be considerable overlap of presenting symptoms, as I said earlier, of storage and voiding dysfunction. Example, a patient of enuresis and stress incontinence can have impaired sensation of bladder fullness as well, and more frequently with detrusor underactivity. We have to rule out other important factors via history, like culture-proven recurrent UTIs in the past, any bowel dysfunction, especially constipation, past pelvic, abdominal, or spinal surgery, her previous mode of deliveries, intake of medications which can impact voiding, or any neurological symptoms like back pain, sciatica, lower limb paresthesia, or weakness. When we come to clinical examination, we have to assess the patient from head to toe. No matter what system we are dealing with, this is a dictum. So when we are doing general examination, assessment of mental status of patient is very important, specifically in voiding dysfunctions, because that can give us an idea of her alertness, engagement, cognitive function, and mobility, presence of any edema or obesity, and any abnormality in her gait leading to restriction in mobility or dexterity, which can be associated with any other systemic disorder or specifically presence of any neurological deficit. Clinical examination is not complete without upper abdomen and a pelvic examination, where we must rule out an enlarged bladder suggestive of retention of urine, or palpable pelvic mass which warrants further evaluation of the other systems. Pelvic examination per se would rule out any structural lesion which can cause extrinsic like urethral diverticulum or urothelial malignancy. Other gynecological malignancies or benign conditions like prolapse of any compartment, especially greater than stage 2, are one of the important reasons of extrinsic compression of urethra. Assessment of pelvic floor tone is important to complete the examination, and also presence of any other tender points, nodules, or myofascial bands. Neurological examination, as I say, is incomplete without a comprehensive assessment of especially the sacral neural pathway, S1 to S4, which can be done by assessment of perineal sensation, bulbocavernosus reflex, rectal sphincter tone, and ability to contract the anal sphincter. So much so it is said in the literature that to evaluate neurological system of such patients with voiding dysfunction, if a clinician finds himself or herself, not competent enough to be assessing these things, a proper neurological referral needs to be taken.